Hello and welcome to the Clinical Care Options Oncology podcast. I'm your host, Sharif Mursalan. In today's episode, we are joined by Dr. Zev Wainberg from UCLA, Dr. Funda Meric-Bernstam from MD Anderson Cancer Center, Dr. Alexandra Leary from Gustave Roussy, and Dr. Catherine Fahey from Massachusetts General Hospital. They will be discussing current considerations for monitoring and managing adverse events associated with HER2-targeted ADCs as treatment for patients with genitourinary, gastrointestinal, and gynecologic malignancies. This episode is a part of our broader educational program titled Emerging HER2-Targeted ADCs in Genitourinary, Gastrointestinal, and Gynecologic Malignancies. For more details on our presenters and to access the full program, be sure to check out our show notes. Now, let's get started and hear what our experts have to say.
Hi, my name is Dr. Zev Wainberg. I'm gastrointestinal medical oncologist at UCLA.
I'm Funda Meric-Bernstam from MD Anderson Cancer Center. I run the Phase 1 program, which is the Department of Investigative Cancer Therapeutics.
I'm Alexandra Leary, and I'm a medical oncologist specializing in gynae tumors, so ovarian, cervical, and uterine cancer. And I'm based at Gustave Roussy in Paris, France.
I am a GU medical oncologist, so seeing prostate, kidney, and most relevant to this talk, seeing bladder cancer patients. And I'm at the University of North Carolina in Chapel Hill.
So current HER2 antibody drug conjugates that are approved, as well as those in development, differ quite a bit in their adverse event profile. The predominant determinant appears to be the payload, although some of these toxicities we're seeing may be target-related.
The way I explain it to my patients is you're going to have two different categories of toxicity on an antibody drug conjugate. The one is something you're very familiar with, which is the cytopenias, the anemias, we're going to watch your counts. And then the other, alopecia, which is I've seen in a number of antibody drug conjugates. Some people have hair loss and some people have sort of the intense cytotoxic side effects. And then there are others that are, like you said, neuropathy with vedotin and with exatecan and topotecan derivative payloads. We see a lot of GI toxicity. So we warn patients certainly about diarrhea and nausea and making sure that they're managing it. There's a whole other group of side effects which are, a little bit unusual and outside of the typical stuff we would see with chemo, which includes either interstitial lung disease as the predominant one, but even some other more obscure ones. And so I think that that's been shown in the clinical trials, in the large clinical trials that have looked at these drugs, and breast cancer, certainly, and gastric cancer and others. And it's very important that we warn patients about these toxicities. And they've also been manifested in real-world evidence studies. Dr. Leary, I wonder if you could go over some of the differences between on-target and off-target toxicities. Does the linker matter? Does the DAR matter? Of course, the payload matters, but maybe you can help us talk through some of that.
Yeah, I think we have to say humble because I think we don't understand all of it quite yet. For example, in terms of target effects, I find it fascinating. It's reassuring, fascinating that we don't get more cardiac toxicities with HER2-targeted ADCs. Can someone explain? It's great, but myocardial cells express HER2, and it doesn't really seem to be an issue, right? And we have other ADCs that have these curious ocular side effects, okay? We thought initially it had to do with the target. It probably has more to do with the payload. So I think we're learning, but I think we're still far from understanding all of these. And I think it's going to be important as some of these ADCs are being proposed in the maintenance setting. We've talked about combining them with chemo, but a lot of studies are using them after chemo as maintenance. And while we're used to maintenance, we use it a lot in gynae cancers. And maintenance with something like an immune checkpoint or bevacizumab is not the same as maintenance with an ADC. It is, and it still remains cytotoxic. And to some degree, while our patients are willing, they live with a little bit of lymphopenia, thrombocytopenia, anemia, that doesn't bother them so much, probably except if it's grade 3 or 4. But grade 1, 2, nausea, diarrhea, those effects bother them more. And so I think we still have a lot to learn about this. I don't think we understand everything about these side effects. They don't make sense always from an even biological or pathophysiological basis. I don't always make sense of them. So I think we have to keep being very cautious. And as you said, we know some of these dangerous ones like ILD, people are really learning, thanks to other tumor types where ADCs are much more used, to really intervene early in the case of a suspicion of something like interstitial lung disease, because some of them can be fatal if you don't take them seriously.
Yeah, I mean, first of all, really good point about the echoes. I mean, should we be doing them at all is a fair point. I think this isn't trastuzumab I mean, in breast cancer, it's a little different, right? Because these drugs are incorporated off in the adjuvant setting. So in breast cancer, women will have been on these drugs and have an expectation of survival of many, many years.
Yeah.
Whereas in advanced disease, sadly in gastric cancer, at least where I've used trastuzumab for a long time, we don't necessarily even see the long-term toxicities of cardiomyopathy because sadly patients don't survive that long the majority of the time. But in these ADCs, it is interesting, right? We're supposedly targeting HER2,
yeah.
and yet we're not having a meaningful impact on ejection fraction.
Yeah.
So I've noticed that too, and I haven't heard a great explanation either.
No.
But I think, the ILDs are important to spend a few minutes on because the ILD is really the stuff that we're warned about. We knew very early on in the development of these drugs, I remember from the phase 1 with TDXD at least, that it was a clear.
For trastuzumab deruxtecan, an important adverse event of note is their potential risk for pneumonitis or interstitial lung disease. This is something that could be monitored closely during imaging that's done routinely at the time of restaging. It's important to evaluate the pulmonary fields to see if there's any pneumonitis related changes, because the goal would be to be able to catch any early pneumonitis when it's still grade 1 that is asymptomatic. If there is signs, radiographic changes that are suggestive of pneumonitis, the recommendation is to hold treatment and then do a full assessment, looking for alternate causes, including infections, potentially get infectious disease or pulmonary consultations, consider bronchoalveolar lavage, consider early re-imaging, and consider steroids for treatment.
There's a scale of what we consider to be clinically ILD, and the first scale is obviously that it's not something that's identifiable only on imaging, essentially a pickup on imaging, which has no clinical manifestation. It really is something that the radiologist points out and that we see on the imaging, these ground glass opacities, perhaps some degree of interstitial findings that are a bit different, and those patients are often monitored, and then from grade 1 through 4 it gets progressively worse, and you have symptoms, whether it's low-grade symptoms like shortness of breath on exertion or more serious symptoms like hypoxia and requiring oxygen. And we know now that we have guidelines on how to manage these, when we should stop the drug, when we should give supportive care. And I think it's critical, at least in my opinion, to get a good pulmonologist to work with so that you can, get a good feel about that. And I think early on, we didn't have a good feel about that, which is why if you look at the early studies, when we did some of these studies in colon cancer and in gastric cancer, we saw grade 5 events. We saw grade 5 ILDs on these earlier reports that are really sad and not an insignificant number. If I recall in the original study, there were, up to the 5% of patients, and there were a number of deaths associated with this. So, I think now we have a much better handle on this, and it's a much more multidisciplinary situation, so we can get more specialists engaged. I don't know, Dr. Fahey, if you have experience with this ILD, but it's a very tricky toxicity to manage, and I don't know if you have a protocol there on or a pulmonology team that you work with to help.
Yeah, it's really, really tricky to deal with, and I really appreciate your point that we need to recognize these things promptly, and so that we can start treatment as quickly as possible. And, pointing out that there is a risk of death in the Destiny Pan-2. There were 3 deaths from ILD, including one of the bladder cancer patients. So we do work really closely with the pulmonology team here. There is a group of people who have a particular interest in immune checkpoint inhibitor toxicities. Obviously, the overlap between the ILD of an antibody drug conjugate and the pneumonitis of a immune checkpoint inhibitor, there's some overlap in interest there as well. So we have some really excellent pulmonology colleagues that we definitely get involved when we're dealing with patients with, new severe hypoxia concern for ILD from a HER2 drug.
I think the adjudication has been really good overall in the programs. I think there has been sort of enhanced recognition and comfort, and that's true of any drug. We all know, it sometimes takes time for us to understand a toxicity and learn how to manage it. And this certainly is no exception. And I think to the points made earlier, and with checkpoint inhibitors, we're going to see more ILD. That's one of the things we have to brace ourselves for, and how to manage those, particularly when to start steroids, is going to become important in the next few years. And, with immunotherapy, it's not been easy, I have to say, because, one thing we worry about obviously is overlapping toxicities. And with cytotoxics, the overlapping toxicities in antibody-drug conjugate are usually going to be cytopenias and all these things that we're more familiar with. And then with immunotherapy, PD-1 inhibitors or other checkpoint inhibitors, we're encountering other toxicities like interstitial lung disease and ADC-associated toxicities. So it won't be so simple. Dr. Fahey, do you have any? I mean, you commented on the DV toripalimab study, which is maybe one of the good ones out there.
Yeah, I think the big question is the pneumonitis. With the trastuzumab deruxtecan, in many of the trials, the pneumonitis rates were consistently between 8 and 10%. You all can correct me if in some of your disease groups you're seeing different rates, but everything that I've seen has been in that range, which is quite high. And I think when we're talking about HER2 therapies, we're often dealing with aggressive cancers, risk benefit wise, it makes sense. But it gets really hard to tease out if we're going to combine the trastuzumab deruxtecan with an immunotherapy. Pneumonitis, is it from the HER2? Is it from the PD-1? We're giving steroids either way. How much, does it change if it's from one or the other? I will say in bladder, we are not combining them at this point. The trastuzumab deruxtecan with an immunotherapy. Right now, the approval is for monotherapy based on the pan-tumor. And then the disitamab vedotin with PD-1, we don't see the same pneumonitis to my knowledge. Now, I'll be fully transparent. I haven't gone through all of the trial data from the phase 1/2, but to my knowledge, we don't have quite the same levels of pneumonitis. I'm anticipating the toxicity should be similar to what we see with enfortumab vedotin, where really the neuropathy and rash are the biggest things we deal with. Now,
so you don't have a big pneumonitis problem in EV plus Pembro?
No, I haven't seen substantially higher rates of pneumonitis with EV Pembro than with Pembro by itself. Certainly we have our risks of any of the itises with our immunotherapies.
That's interesting. A different ADC, different construct, obviously different payload. So, or the same payload for vedotin, but different than the payload for trastuzumab deruxtecan, certainly. And I think the section of toxicity is challenging because you have off-target, on-target side of toxicities you can tolerate, some you can't. I think that I'll start with GI cancers where, like I mentioned, we are trying to combine these drugs up front now with chemo. And one thing that we're encountering is a lot of cytopenias, which are requiring dose reductions, which is challenging because, you don't know what dose to reduce when. You don't know what drug to reduce. You don't know how to restart. We're all kind of learning on the fly with these ADCs. Well, I wonder if we could talk a little bit about the future. I think that how far can this go with these antibody-drug conjugates? How far can we push it, or can we move all these drugs up front? That's a big question, I think, in a lot of cancers. Dr. Leary, you talked a little bit about ovarian cancer, moving it even earlier. Do you think this is a wise decision, or what do you think?
I mean, I think it has to be tempered with the risk of the disease. If you're going to be moving drugs like these into the adjuvant curative setting, then it has to be guided by the prognosis of these patients. And it so happens that we're moving it into high risk. So although these patients will have benefited from complete surgery, we know by their histology that they're at a very high risk of metastatic relapse. So I think it has to be balanced by, the risk of metastatic relapse for these patients. I think that as a medical oncologist, I always want to increase cure rate rather than spend my time treating relapsed metastatic disease. I also think that at least in breast cancer, where they have used HER2 ADCs for a long, long time, and they can stop them, and patients are in complete response, I think we also have to keep our eye on the ball, whether in some instances we may be curing metastatic disease with some of these agents. It'll be a rare instance. That's a fantastic thing. I mean, cure still remains our priority. So I think it's important to safely move them into the curative setting in diseases that have a risk of relapse that justifies that approach. And I think the next question will be, how long, right? What is the duration of these? When you are treating a disease that you can see and that's shrinking into your eyes, that's one thing. But if we're moving them into adjuvant setting where we don't see the disease, how long are we? What's the right length? And there it's going to require a lot of fine tuning.
Yeah, I completely agree. And I mean, in GI, for example, this is a big debate because, so I think like one of the things that we're all saying is the HER2 is different, right, in different cancers. So we can learn only so much from breast cancer, in my opinion. We can learn, for example, about toxicity profile to some extent. We can learn about, expectations, but we also know that, HER2 is a different thing in gastric and breast and ovarian and bladder. So, just because the drug worked exceptionally well in HER2 1+ and breast cancer does not mean it's going to do the same in these other cancers by any stretch. And because I've been doing HER2 trials for a long time in gastric cancer, and we were very tempered because early on there was this expectation with anti-HER2 trastuzumab would work in the advanced setting, it's going to work in adjuvant setting or perioperative setting. And a lot of those studies were very negative. There was no clear evidence that moving a HER2 inhibitor up front, and there still is no evidence that moving a HER2 inhibitor up front in a disease like gastric cancer helps survival. Now, some of the studies were a little, inconclusive, and some of the studies were probably not selecting patients the way we ought to be in this, in this era. But nonetheless, we did not have a clear signal that there was any evidence that moving these drugs up front. They're trying to change that, and particularly in the perioperative setting, which is what we do in gastric cancer, we're trying to treat neoadjuvantly before and then adjuvantly after. But there, the standard of care is multi-agent chemotherapy. So we have to figure out how we're going to possibly incorporate this into that context. So with surrogates, I think, like you mentioned, pathological response rate, and Dr. Fahey, you talked a little bit about that in bladder, and we're trying to think if we can extrapolate that. But I think the point is really well taken that these are different expectations, and we have dual challenges. First, just because we have new drugs doesn't mean we should use them in everybody. And it certainly shouldn't mean that when we go into an adjuvant context, we expect the same benefit across the board. And I think that's a really good point. So, and I'm sure Dr. Fahey, in bladder cancer, you're kind of in line with what we're saying here.
Yeah, I could not agree anymore with the points that the two of you just made. Very well said.
I really want to thank both of you. I know that we're all sort of excited about this field, antibody-drug conjugates, HER2 targeting across the board. It's been really fun for me to learn a little bit about bladder and endometrial and cancers I don't know much about. So I'm happy to see that we're all excited about this field. I don't know if any parting thoughts, Dr. Leary from Paris?
I would say it's a tsunami of ADCs. We need help to know how to sequence them. That's going to be our major, major, major problem is how do we sequence them. So,
and I think we're going to need global studies, right? It's not going to be sufficient to just, as we talked about earlier, show response rate in one region. And we have to do like these big global studies, I think, to answer this.
Well, HER2 remains a really exciting target, and there are several different strategies being developed, other monoclonal strategies, as well as small molecule inhibitors in development. In addition, there's a lot of drugs in development that have immuno-oncology strategy. And so these include, engagers, CAR T cells, bispecifics. So it's going to be a very interesting time over the next several years to see how these agents evolve.
Dr. Fahey, I'll let you have the parting word.
I think that this has been just a wonderful conversation. It's been so interesting learning about the perspective each of you have. And I really appreciate all the points about making sure we're selecting the right patient populations with the right HER2 biology to go after. And also the points about not all diseases are the same that were made by you, about, making sure we're thinking about this correctly and moving forward correctly. The tsunami is coming, the tsunami is here, and it's going to be a lot of work to figure out the right way to do these things.
Thank you very much for listening to our podcast today. I hope that you were able to learn and gain some insights into the landscape of emerging HER2-targeted ADCs in genitourinary, gastrointestinal, and gynecological malignancies. If you missed our first 2 podcasts on this series, please go back and listen to our thoughts on the lay of the land, the biology of HER2 and genitourinary, gastrointestinal, and gynecological malignancies, and some details on the clinical trials.
Thank you, Dr. Wainberg, Meric, Leary, and Fahey for a great discussion and for sharing your valuable expertise with us. And of course, many thanks to you, our listeners, for joining us today. As a reminder, you can access the full program, Emerging HER2-Targeted ADCs in genitourinary, gastrointestinal, and gynecologic malignancies by clicking the link in the show notes. Be sure to check our previous episodes in this series, including Episode 1, The Lay of the Land, an overview of the biology of HER2 in genitourinary, gastrointestinal, and gynecologic malignancies, as well as Episode 2, Taking a New Path, evaluating current and emerging clinical data with HER2-targeted ADCs in genitourinary, gastrointestinal, and gynecologic malignancies. Thanks again for listening, and we'll see you next time.